Good afternoon, everyone, and welcome to the COVID-19 and Health and Equity Seminar Series, presented to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. This is the fifth and final seminar of the series. I am your moderator for today, Tiffany Lemon, and we are excited to welcome Dr. Joseph Lunard of the UC Berkeley School of Public Health. Before we get started, let's cover a few logistics. The seminar is being recorded, so please turn off your camera if you don't wish to be recorded. This recording will be available on our website at a later point in time. At approximately 2:45, we'll stop for questions. Throughout the talk, you can send your questions to Tori Calger via the chat function. We are thrilled to have Dr. Lunard with us today, as he describes an ongoing study of the epidemiology of COVID-19 and the impact of the pandemic among farm workers in Monterey County, California. This study is undertaken in partnership with Clínica de Salud de Valle de Salinas, the primary care provider for healthcare in this population. Farm workers are an essential workforce population in the US whose continued work during the COVID-19 pandemic has been critical to the security of the food supply. However, the living and working conditions of this population, together with profound social, legal, and economic marginalization, have created a perfect storm in the context of COVID-19. Without further ado, let's get started. Thank you for joining us, Dr. Lunard.
Thank you so much for the invitation, and thank you to everybody who's attending or listening later on. I really appreciate the opportunity to give this presentation to old colleagues from CCDD and many who I have not had the pleasure of meeting. So I apologize first. Unfortunately, Dr. Maximiliano Cuevas, who is our main partner and the CEO of Clínica de Salud de Valle de Salinas, is unfortunately not available to join, and but has been an instrumental partner in making all of this work come together along with everybody else based at CSVS. And so all of the work that I will be talking about has been done by a huge team, also led on the side of UC Berkeley by my colleagues Ana Maria Mora-Wairobrek and Brenda Eskenazi. So I think that many people have heard of Monterey County, California, and could recognize it even by pictures. It's located just to the south of the Bay Area, and is known for its natural beauty and the Highway 1 seashore, famous sites like this. But underlying all of this natural beauty and just a few miles inland is a very different reality that contrasts greatly to the kind of outward image of wealth and really exclusivity that we know from towns like Carmel by the Sea and other 17-mile drive in places like this. Inland, just a few miles, is a very different reality for over roughly 100,000 farm workers along the Highway 101 communities of John Steinbeck's Salinas Valley, which is one of the leading agricultural regions actually of all of California and in fact the United States. Many refer to it as the salad bowl of the nation due to what is grown there in a very temperate kind of year-round growing season, in contrast to the Central Valley of California, moderated by the ocean breeze and sort of a cooler climate and wetter climate. Unfortunately, the circumstances of life, as many can imagine, for this population are far from ideal. And this was, exacerbated not only this year by the COVID pandemic, but also by the horrible wildfires that occurred in California. Many of them, in fact, centered right around the Bay Area and in Monterey County itself and the surrounding areas, with devastatingly bad air quality, during which farm workers, continued to work the fields in the context of all that was going on. And so there are many really tragic images actually of scenes like this where air that is just simply not suitable to breathe is the environment of work for this large population of people. Aside from the working conditions, which are difficult to say the least, Monterey County is a not cheap place to live, and it is certainly wrapped into the broad housing crisis that California faces as a state right now. There have been many reports into the grave situation that farm workers face in terms of housing this year, and some images from news articles that I've aggregated here just to sort of illustrate the scenario. There's, vastly prevalent overcrowding in housing. Many people live in somewhat makeshift accommodation, including hotels that are rented out and repurposed by growers or other parties for farm workers to live in, and many people living in garages, mobile homes, et cetera, that are really stuffed to the gills with people. And this, of course, although it's been a crisis that predates COVID-19, has received fortunately renewed attention amid the ongoing pandemic and what this means for transmission of an infectious disease. Farm working communities are not favorable to workers in many ways, and they form, in the sense, the base of a pyramid of a kind of social hierarchy that exists, that has growers essentially as the high earning peak of a pyramid, who often contract work out through farm labor contractors. This is not necessarily the model of every single farm, but it is a predominant model where farm labor contractors, who might be former farm workers themselves, hire usually mayordomos or supervisors, who then go on to hire the farm workers and have much influence over all aspects of their life, not only their working arrangements, hiring and firing, and job security and wages and things like that, but also are often in particular in the context of a population that has limited acculturation, limited English proficiency, and ability to get by in the United States. They might be also responsible for basic aspects of living arrangements, such as where people live and how they get housing, their transportation to and from work, and many other aspects of their navigation of life in the United States. One of the complexities of this arrangement, of course, it's been well documented in previous studies that farm workers are more likely to receive less pay than they are owed, which is already quite low, and more likely to have payments missed or withheld when we have farm labor contractors as sort of a middleman in this arrangement. So the circumstances of their life in the United States are subject to many constraints, not only legal ones, of course, as many can imagine for this population, but also in terms of their economic arrangements that sustain farm work. So, of course, when the COVID pandemic hit California and Monterey County in particular, my colleagues at the School of Public Health, who've had a long history of engagement, became very active in addressing the circumstances that were arising. So my colleague, Brenda Eskenazi, who is also on this call and will be answering questions later on, pictured here, has run for over 2 decades a Chamacos birth cohort study of the effects of agrochemical exposures on health and child development in the Salinas Valley of California. So a long history of working in this population with many community partners, including CSVS, which is the healthcare provider with whom we worked on this study, as well as Natividad Medical Center and many community-based organizations, too many to name in short span of this talk, in fact. Our other colleague, Ana Maria Mora-Wairobeck, has been part of many of these studies and also runs studies of farm worker health throughout Latin America, including in Mexico and Costa Rica, as well as in Uganda. So it has a lot of expertise to bring to this situation as well. I have none, actually. I am a new faculty at Berkeley, and I work on infectious diseases. Have no history of working in farm worker health whatsoever, and no qualifications to do so from any perspective. But early on in the pandemic, I was aware of Brenda Eskenazi's advocacy, and she reached out to me about whether modeling a situation like this could lead to any kind of insights or help. And I said, I don't think that modeling is really of value here. I think that a real epidemiological study is called for. And so I've been very lucky to tag along on this undertaking. Another notable development while this has been going on is that Dr. Eskenazi, along with Dr. Hester Parker at Cal State Monterey Bay, and a broad set of other community partners have developed a Monterey County Coalition on Agriculture, specifically to address the living and working and health concerns that are uniquely faced by farm workers in the context of COVID-19. And this is a very unique advocacy group insofar as it is, I think, one of the only models that has succeeded in bringing together farm workers and growers and their representatives, which are a population that for decades has been, difficult to bring together for many reasons. And this also includes many community-based organizations, county officials from the health department, and other sectors of county government, as well as academics who have united in efforts to advocate for needs of farm workers at various levels. This has succeeded in, for instance, getting procurements of PPE for farm workers in the fields, raised awareness of the concerns about access to testing and needs for testing, and influenced how, for instance, CSVS in Monterey County proceeded with enhancing the availability of testing for farm workers in this area. So there's a history of engagement here that really created a opportunity to do something meaningful in terms of a study in this population. So in terms of what this study is, we set out just broadly with the interest of learning and monitoring what is going on with COVID-19 among farm workers. There are many news articles and anecdotal reports coming out about the situation being grave, and for many reasons one can imagine that this would be the case. However, to my knowledge, after watching this closely for a long time, there's not been a lot of actual epidemiological evidence of the extent of infection and what is going on, where infection is happening, and how it can be prevented. So this is what we set out to contribute. Our partner is Clínica de Salud del Valle de Salinas, which is a federally qualified health center that has operated for 4 decades, actually, since 1980, operated by and founded by Dr. Max Cuevas, who is actually a former farm worker himself, grew up in a farm worker family, and knows the population very well. It's a network of 12 clinics that provide essentially primary healthcare throughout Monterey County, really targeting the underserved population of farm workers and their families. It treats about 50,000 patients a year with about 200,000 appointments, so it's a very high volume operation. And they initiated SARS-CoV-2 testing in June under the support of a HRSA grant, which specifically was necessary here for giving testing to a population that does not have access to health insurance for the most part. As of mid-October, just a few days ago, the most recent count was that 10,558 tests have been conducted with a sustained positivity rate of over 20% through all of their cumulative operations. We have been very lucky to work with them in doing this study, both through in-clinic operations and outreach. We initially, in starting the study, wanted also to be conducting testing in fields and essentially, getting farm workers where they work. And unfortunately, I've encountered massive opposition from growers in actually making that become a reality, as well as grower organizations. We've had students call over 300 growers from a comprehensive list of all growers in Monterey County, and have not had success in bringing the study into that particular environment under the auspices of growers. So we've been lucky to work at clinics that serve this population. However, can speak now to, I think, some of the key barriers to farm worker health on the employment side, in fact. So in terms of the procedures of the study, we're enrolling individuals who are ages 18 years or older, who at least at the outset have been engaged in farm work in the last 2 weeks. So we started the study in July. The growing season is now kind of winding down to a close. And in addition, the extent of agricultural operations was reduced this year in light of economic hardships associated with the pandemic. And in fact, this is one of the most interesting things to study about what is going on now, since there is a large farm worker population that is underemployed relative to historical trends. So we've recently expanded this to, in addition, enroll farm workers who've been engaged in farm work, broadly defined, in the last 12 months, to also find out what is going on for the population that no longer can work in farms because of what is going on right now. For various reasons, we're enrolling people who are not pregnant and people who are primarily coming in to receive a diagnostic test for SARS-CoV-2. So this can include essentially people who are cases, who have symptoms for which they are interested in receiving a test, as well as really anybody else who is coming into various outreach or clinic-based test operations. There's widespread community-based testing, as well as sort of tents set up outside the CSVS facilities to ensure that essentially anybody who wants to get a test can get a test. We're collecting several specimens first for various ethical reasons that involve reporting of SARS-CoV-2 results for a largely undocumented population. We're relying on a release of PCR results to us at the consent of participants, rather than being the notifiers to the county and to the government of who is positive and who is not. This is a very big concern, and I think it's been well reported, largely actually by work by Dr. Eskenazi, that the current immigration context and situation that has emerged since 2016 has become a barrier to healthcare seeking for this population, none less in the context of knowledge that they will be called by the government and traced if they are found to be positive. Unfortunately, we also get a venous blood draw, which goes to the laboratory of our great colleague, Dr. Eva Harris, to look for antibody evidence of previous infection from RBD and spike IgG. We, in addition, get a saliva specimen, which we received funding to study for commensal bacterial carriage and co-infections in the context of SARS-CoV-2 with Dr. Lee Riley and our great friend Ann Wiley, now of fame for saliva-based testing of SARS-CoV-2 and low barrier testing in general. She's based at Yale. In addition, subjects answer a detailed, roughly 45-minute questionnaire by phone shortly after being tested and before receipt of their results. And then all specimens are banked in a biorepository for future farm worker health studies, which is run by Dr. Nina Holland, who's a very long-term collaborator of Dr. Brenda Eskenazi and partner in the Chamaco study, which has been a very kind of productive exercise in developing long and extensive bio specimens for studies of various exposures and health outcomes in farm worker populations. So in terms of who's been enrolled so far, we have enrolled, as of the time of the data that were updated in this presentation, 704 individuals who completed interviews. We're going at least through the end of November, anticipating enrollment of a little over 1,000. About half were male, which is a little bit less probably than the true distribution of workers, but we're catching maybe a larger sample of women than would usually be caught in studies of this nature, in particular because we're based at clinics where they might be bringing children in for care as well, which has been fortunate to be able to capture the female farm workers as well. Median age is 40 years, and most are sort of young or middle-aged adults, although there is a bit of a tail towards very old individuals, over 60 years. In the country of birth for almost all is Mexico, including Oaxaca, and those from Oaxaca will usually say the country of birth is Oaxaca. The US for a smaller proportion, mostly of younger individuals, and then a limited population of people from Central America and other Latin American countries. In terms of language, we are conducting interviews in English and Spanish. There are many indigenous languages spoken as well in this population, which is interesting facet of also the farm worker population in California and including in Monterey County. Many are in fact not fluent in Spanish and might speak languages that are either not written or in which there might be limited services and availability of information, including the largest in our population is Mixteco, although there's also Triqui Zapoteco, which is spoken in and then various other languages that are represented. A substantial proportion have fairly low levels of education, including, from having never attended school to only really elementary level education being completed, and only 17% have high school diploma or equivalent level of education, which is roughly representative also of the situation for farm workers throughout the county and the state. In terms of housing arrangements, we were, curious about this aspect also because we're interested not only in, how many are infected, but where they might be getting infected and what are the risk factors. Half report living in a house and some more in sort of formal traditional apartments, although these are, still, as I said, not apartments as many of us would, envision them, but, ones where there might be a limited number of rooms and beds in every room in order to, accommodate the number of people that need to share a home to make ends meet. We have caught some people living in group housing, which includes hotels and motels, dormitories, farm labor camps, and shelters. About 5% of people, the shelters are in this category, and then other settings, including mobile homes and trailers, garages, and in sort of informal arrangements like that, rented rooms and houses, and some homeless individuals as well. The homeless finding is especially striking because these are active workers, who are engaged in work in the last 2 weeks, and I think that should be remembered when you call out that some of these people are in fact homeless. 39% report overcrowding as it would be defined by the US and UK traditional definitions of over 2 people per bedroom in a home. And this is compared to 2% in the country at large. So really a substantial extent of overcrowding. Over half have more than 3 people sharing a bathroom as well in these houses. 75% live with children, and 5% in this context have said that their children have had access to school or daycare. Of course, schools have been closed during this time, but this also, speaks to the needs that are for childcare arrangements that are not being met. In terms of the characteristics of work for this population, I've listed out the types of crops that they're involved in growing, which is broadly representative of what is grown in Monterey County. As said earlier, it's a salad bowl of the nation, so leafy greens are a big part of this. Strawberries, this was, we call it sort of the tail end of strawberry season in the Valley. If you've heard of Driscoll's or other, sources of strawberries, they probably came from Monterey County. So you can look next time you're at the grocery store. Raspberries, blackberries, there's a lot of berry farming in general. Over half have incomes for their entire family, including all people who are working, of less than $25,000 a year. And there's sort of a very small proportion of people earning what is still probably below the necessary amount of money to live in Monterey County. The size of companies varies. There's people working at very small operations, from under 25 workers to well over 500 workers. Of the people that we've caught, 5% report being a supervisor or mayordomo. And in terms of how their arrangements for getting to work look, about 35% report sharing transportation with non-household members on a daily basis to get to work. So this includes carpool arrangements and ride shares and trucks or bus, which are often operated by growers or by FLCs or mayordomos to get people to the fields. This, of course, is, a concern as well, crowded transportation with, non-household members for getting to work. So in terms of what we've found from studies of the specimens we've collected, we've gotten we've gotten from all 704 people that we've enrolled so far bioassays, but for various logistical reasons, I'll be talking about the results from 321 PCR tests that we've linked back from the clinical records to individuals in the study, and then 300 antibody test results that have been processed to date, covering up until mid-September by our partners at Berkeley. So 30% of all participants in this clinic-based sample report any symptoms that could be associated with COVID in the 2 weeks before participating. And so this is helpful to consider when we will be stratifying all the results we present by those who are symptomatic and are essentially likely COVID cases getting tested from those who are truly asymptomatic and are just getting tested on a surveillance basis here. Among those with symptoms, we see 25% prevalence of infection by PCR. And of those who are infected in this symptomatic, so true COVID cases that could, based on all, criteria be, people that you would not want in a workplace, and who are, symptomatic and therefore easily ascertained as, potential COVID infections. 63% report working while symptomatic, going to concerns about what would happen if they did not go to work economically and in terms of job security. Among those who are not symptomatic and who are just essentially, being tested as, for a purpose of surveillance in this setting, we see an average over the course of the study of about 9% prevalence by PCR. So very high infection among people without symptoms. And over the course of the study, although I'll be talking about this a little bit later on the next slide, on average, we've seen 15% seroprevalence by spike IgG for specimens processed through September 17th. Among those who are antibody positive without current symptoms, about 21% report a history of symptoms that could be associated with COVID. So we're mostly catching people who would not have been suspected to have been a case earlier on. In terms of trends over time, the antibody prevalence is probably the most striking thing to note here because, many people like to look at antibody prevalence as, a measure of cumulative infections, and we can monitor essentially zero incidence in a fairly unbiased way by looking at month-to-month changes in antibody prevalence. So among asymptomatic persons being tested through this program, we've seen essentially from July, the outbreak progressed from already, extent that's far worse than the greater extent of the outbreak in California of 7%, to 20% by mid-September. And we'll be, watching this in the next batches of specimens that we process to see what's happened, since then. Among symptomatic persons being tested, those with symptoms the last 2 weeks, we've seen 12, 22, and 35% prevalence through July, August, and September, respectively. So far in October, the prevalence of infection among those with symptoms is actually a little bit lower, so it'll be interesting to see, how this trends going forward. And then among asymptomatic persons, it's hovered sort of in a lower range as of July. Among asymptomatic persons being tested, it was quite high. It was actually 17%. There's been, a sort of trend downward from that point. And for so far, among the people getting tested, just who are without symptoms in October, it's been quite low. So we'll be, looking to reconcile what we're seeing in terms of current infection with the sero incidence that we monitor from month to month here. In terms of the symptoms that are associated with SARS-CoV-2 infection in this population, it's pretty much every symptom that you can name as, an upper respiratory symptom or lower respiratory symptom with difficulty breathing, et cetera, are strikingly associated with COVID, with SARS-CoV-2 infection. In addition, the loss of taste and loss of smell, which were added on later, are in fact quite good predictors of someone being a COVID case. They're not necessarily seen among all of those who were infected. It's only about 15% of those who were infected in our study are reporting these symptoms, but it's strikingly specific predictor, 16-fold odds ratio for the likelihood of being infected given that symptom is reported. Next, I'll be going kind of briefly through some, preliminary analyses of risk factors. These are, not, at a final stage, but they give some illustration into, the spectrum of infection and who is getting infected. So just looking at the outcome of being PCR positive in this population over the course of the study, we don't see, extreme differences by age or sex. Notably, also not between Spanish-speaking and indigenous language-speaking individuals. We do see, a sort of split between those earning less than $50,000 and those earning more than $50,000, a pretty pronounced difference in infection, with 15% among those earning less than $50,000 versus 3% among those earning more being infected. In terms of the country of birth, those who are coming from Central American countries essentially are found to have higher prevalence of infection than those from Mexico and the US. In terms of education, we can see that those with no history of schooling, followed by some schooling and who attained high school diplomas have higher, moderate, and essentially no prevalence of infection among those who've had tests linked to the data that we've collected. Those in group quarters, which is a limited number of those for whom we have testing, but strikingly do have far higher prevalence of infection than those in non-group quarters. In addition, there's a sort of suggestion of an association with crowding. Those in very highly crowded accommodations, more than 4 persons per bedroom, do have the highest prevalence of current infection. We don't see a very big difference in terms of the current infection status for those with children at home, although I'll be talking about this with respect to antibody evidence of previous infection. And then last, people who've had contact with a case that experienced acute respiratory illness in the last 2 weeks have far higher prevalence of infection as might be expected. This is probably a good indicator that someone's exposed to a COVID case in the event that that person is not ever diagnosed with COVID. We see 41% versus 13% prevalence among those who have no knowledge of being exposed to a person with acute respiratory illness. Likewise, those who have history of contact with a known COVID case have higher probability of being infected. In terms of workplace exposures, again, very simplistic analysis here, just looking at the distribution of these risk factors among people in the study. We also see that contact with a person who had acute respiratory illness in the last 2 weeks is associated with higher prevalence of PCR positive status. In addition, shared travel to work with non-household members is seeming to be associated with about 2-fold higher prevalence of infection in comparison to those who do not have to travel with people from outside their household to work. And this, seems to follow a kind of dose response trajectory also with, the people exposed to, very large numbers, essentially people taking buses to work with other workers have the highest prevalence of infection in comparison to those who are, traveling on their own or with at least fewer non-household members. So this, does certainly raise some, suspicion as to whether the travel arrangements are a big part of where transmission is happening for farm workers. Interestingly enough, I think, my initial inclination thinking about farm work that would occur indoors versus outdoors, we, know, for instance, from, how the infection is transmitted and also the circumstances of work that, have become apparent in outbreaks among meat processing workers and other people in indoor facilities, that could be a big risk factor. Here, actually, we see sort of a reverse where people working outdoors seem to have somewhat higher risk, although this also, falls along a socioeconomic gradient of what kind of farm work is done in the fields versus in indoor facilities likely. So that's another, consideration to bring in here. In terms of, more specific attributes of the workplace and the type of work that's being done, we, have looked a little bit at, what differences there are associated with the specific crops that people are farming. And so we see some differences, in small samples again, and, not, a complete sample of everybody that's been tested so far in the study, but we do see higher prevalence of infection among people who farm peas and grapes, and lower prevalence among strawberry farmers in comparison to those who are not doing strawberry picking. Key risk factors for prior infection, I will not, trouble with going over all of the same ones, but I'll highlight some key findings that emerge here. When we look at prior infection and antibody evidence of infection, we do see somewhat higher prevalence among men than among women. In addition, we see a trend towards higher prevalence of infection among those who have more children in the household, which is, an interesting finding because the role of children and the extent of testing of children have both been, big questions during the pandemic. In particular, those who have children who attend daycare or school or, some place outside the house are at, far higher risk for infection than those who do not have children who attend daycare or school. Again, we see, in fact, here more clearly that outdoor work is, in fact, associated with the greater risk of infection cumulatively when we look at, antibody evidence of prior infection. And then we can see, I've not done this for all of symptoms for the purposes of this slide, but also that we can, catch what look to be previous episodes of COVID when asking people about symptoms they've experienced during the, whole winter and spring for the time until they participated in the study, and see if, reporting any of those symptoms that might be associated with COVID is in fact predictive of antibody evidence of infection. And this is true. And, again, comes out to be, quite specific actually in the case of smell and taste loss. So just briefly, aside from the infection piece, one thing we're interested in learning about is how the population is being affected by COVID more broadly. 34% of people say that they fear losing their job if they have COVID-19. And this has been one of the biggest barriers to getting testing in this population and getting people to enroll in this study. They are fearful that their employers will be notified. And many people report either having lost their jobs because they had COVID and they were fired on the spot for that, or that something similar happened to a member of their family or community. So this is one of the key barriers that's been very hard to shift. More than half will say that the impact of the pandemic has been extremely or moderately negative on their life. Essentially 90% reporting that it's harmed their life in some way. There have been reports of either health conditions being exacerbated during this and difficulty getting care for them, greater difficulty sleeping, and more anxiety, and then many symptoms of depression, so loss of pleasure doing things, and then a more extreme version of that, feeling down, depressed, hopeless. 22% are saying that they've experienced this. Almost 30% saying that they feel nervous or anxiety, and 18% saying that they are unable to manage these feelings. Food insecurity has been a very big issue, and right now what we're doing every weekend is in partnership with CSVS, we're operating the study at food donation events that are looking to address the essentially widespread hunger situation that this population is currently facing. 20% say that they often have worried that food would run out before they can buy more, and over half saying that they have sometimes or often had this. Again, half have said that this actually happened, where food that they bought did not last and they could not afford to buy more when they needed it. Among the adults in this study asked on behalf of their own behaviors during this pandemic, 20% said that they have eaten less than they feel they should. 14% report being hungry because they cannot afford to buy food. 41% say that their family's ability to buy food is lower than it was before the pandemic. And this is, not a high baseline in a population where, the pre-pandemic income for everybody is, or for half of the people is below $25,000 a year. 59% report that they have been sending remittances back to their families or contacts in a country outside the United States, and about half of those people, so 41%, so that they've had to reduce the amount that they're sending in remittances, which is really a grave situation, considering that is a big part of the reason many do come to the United States seeking work. And last, one consideration we've been very interested in is what would be the state of interventions, including a vaccine, if it were to become available in a timely way for this population. And only half say that they're extremely likely to get vaccinated. 21% report being just unsure, not knowing, would this be a good idea? Would this not be a good idea? We have, a sort of, not a majority, but a substantial number of people saying that they're unlikely or very unlikely to get vaccinated. And so we ask them also what reasons might, be behind this. There is, widespread fear that getting a vaccine would give them COVID. This is also, a fear that they, ask our study team about when we take a blood draw. Like, is this going to give me COVID? This is, a population that does not have, great access to healthcare information and, health literacy, and there's, a lack of trust. I think that goes into this. There's also many that don't report trusting the government. Fortunately, this is not really a widespread thing being reported in terms of the relationship with medical providers. And we think, this is also reflective of, CSVS, which is our partner in this, having really a successful and unique history of really providing healthcare to a population that has many barriers to getting it. And, our study team also is members of the community, all the interviewers and medical assistants and research assistants involved, and who the participants are interacting with are community members. And I think there's a level of trust there, which is, encouraging to see that this doesn't emerge as one of the, key barriers to vaccination. And then last, there are some that report being not very worried about COVID or not sure that vaccine would be useful or necessary. So I want to thank you all again. I'll wrap up here. The contact information, I know that questions will come in case there's more questions that you'd like to ask for me, and then for my colleagues that have done a huge amount of this and have far more knowledge than I do about the situation. Dr. Brenda Eskenazi and Dr. Anna Maria Mora Wyrobek are also here. So thank you.
Awesome. Thank you, Dr. Lunar, for such an important presentation. This was really great. Well, next we'll move into some questions. For the next 15 minutes, we'd like to take some questions from you, the audience. Also joining Dr. Lunard for questions are Drs. Brenda Eskenazi and also Dr. Anna Maria Mora Wyrobek of UC Berkeley. We will try our best to accommodate as many questions as we can. However, if your question does not get covered, please feel free to reach out to our guest directly, and they provided those emails on this last slide. All right, and remember to submit your questions to Tori Calger via the chat function. All right, and we'll get started with an audience question. So this question comes from the audience. I was wondering if you could elaborate a bit more about the kinds of questions that were included in the questionnaire. Are there any concerns of bias in responses from individuals who are vulnerable due to their family's immigration status?
So this is absolutely a concern, and it affects all aspects of from the decision to even get a COVID test and be visible to our study, in that respect, to how they would answer questions. I think, in fact, there is a very solid level of trust, which is, in terms of the interview when it's conducted, based on, the questionnaire being developed with, questions and experience from my colleagues that have been working. Sorry, that's my cat. On this population, or with this population for over 20 years, and in the Chamacos cohort study, which guides what we're doing here. Broadly, we do not ask directly about immigration status because of the issues you mentioned, and also because there are also a lot more ethical concerns with gathering that information in a direct sense, or anything that could even indicate somebody's immigration status. Or in documentation status. So we do ask about, country of birth and languages that they speak and things like that, but we don't, ask, are you here on a visa, or questions like that, or what, about their documentation. We ask sort of a broad set of questions about, of course, their symptoms, risk factors for infection, adherence to recommendations like wearing masks, and hand washing, and all of the things that we were told to do, in addition to sort of a long list of socioeconomic questions like the ones I showed about what they earn, and the kind of work that they do, and then in addition sort of a slew of mental health, food insecurity, impacts of the pandemic on their lives and livelihood. But we for the specific reasons of really the ethical implications of getting information on whether someone is documented or undocumented, and how that would impact the rest of the interaction. We do not ask that specifically. I think from what we see, I think there are stigmatized behaviors that they report doing for sure, and there's openness about reporting whether they adhere with all COVID recommendations and which ones they find harder to follow along with. And I think that looking at the information that we're collecting there, I do think that the interviewers are successful and really knowledgeable about how to collect answers to sensitive questions and questions about issues that might be stigmatizing included in that.
Awesome, thank you for that. A question that's somewhat similar as it relates to questionnaire research and designing that questionnaire. Could you speak more to the process of developing the questions and the survey instruments that were used?
Maybe I'll shift this one to Dr. Brenda if you're open to talking about it.
Well, a number of these questions have come from those questions that we've used over 20 years for the Chamacos study. Clearly, things have changed over COVID. And so we were guided by interactions with our coalition about what seemed to be important in the population. Some of the questions, like for example, the food security questions, are derived from USDA questions. Some of the mental health questions are derived from Phoenix. So We tried to use, when possible, existing questionnaires, but for the most part, we weren't reinventing the wheel, we were making the wheel.
And I think, in regard to the specific COVID questions, there's also, there's some, one of the kind of pet peeves I've had in the pandemic is the kind of gesturing about what is a COVID symptom and what is not a COVID symptom. As a runny nose counts and things like that. Or if I have a runny nose, should I be worried? Because I think, first that people are not always great at identifying kind of upper respiratory symptoms like that and other things. So we wanted to collect really as much as we could. And, there's not really a lot of great examples. The CDC list of, at first 4 and then 6 symptoms to ask about and things like that, that we wanted to really broaden what we're doing. I did, take looks at Emma Corsi's great list that she developed and others at CCDD with things to ask about for risk factors and studies of SARS-CoV-2.
Awesome. This next question deals more with interventions that farms have put in place themselves to prevent the spread of COVID. What precautions have farms put in place to protect workers from transmission? And so there's the farm level, and also what has the state of California maybe implemented at the policy level to reduce risk of transmission?
Joe, should I answer that question?
Yeah.
So very early on in the pandemic, when we formed the coalition, the growers actually initiated a number of the interventions, the growers themselves. For example, we wrote a letter to the governor from the growers and the healthcare providers and a bunch of us to provide face coverings very, very early on to the farm workers. I'm talking about back in April.
Wow.
And we received about 120,000 face coverings as a result. There were also a number of efforts by the community-based organizations to start, including the clinic that we were in, to start using this opportunity to employ people to make face coverings, cloth face coverings, and huge numbers were given out to the farm workers. In another study in the Chamaco study that I'm also working on right now, we see that something like 90% of the farm workers have face coverings, and about 70% of them were provided face coverings from the growers themselves. So that is pretty good. Early on also, and this has now been modeled by other counties in California, Monterey County was the first county where the growers started providing emergency housing. And
wow.
this was out of their pocket. So in other words, they weren't getting funding from the state or the feds at this point. And they started contracting with different hotels in the area to provide coverings for sheltering in place, or if someone was waiting for their test results to come back. So there were a number of initiatives that were actually begun by the growers and as well as the CBOs. A very important initiative that came out of our coalition was that the county health department contracted with the California Rural Legal Assistance Program. That's a legal aid group that provides legal aid to mostly farm worker families for a hotline. And so when the money came down from the CARES Act and also from the state provided money early on for undocumented to receive supplemental income, and through the CARES Act for documented. The farm workers didn't know how to fill out the forms. They didn't know what their benefits were. They don't know what their rights are. They still don't know what their rights are. CRLA was there with a hotline. So a hotline was being provided to the farm workers to engage CRLA for free to help them get their benefits. So these are just some of the things that have happened in Monterey County as a result of what we did around providing emergency housing through either the county or the grower groups. There is a Harvest for Homes grant that was issued to a number of the farm worker counties to start similar programs in the Central Valley, for example. So now there will be more emergency housing, but it's not adequate if people are too scared to ask. And that's what my, more based on anecdote more than anything else, is what I'm experiencing. People are just too fearful to ask for their benefits, and they would rather work, as you can see in the data that Joe presented, they'd rather work sick until they can no longer work because they're too sick, rather than stay home and what they think losing income, because they need to support their families.
And we ask about their knowledge of, what growers have told them about, COVID and their rights and benefits. And, everybody has been told by their grower that they should wear a mask in the field, and most report that they do in fact do that or are required to do so. Fewer than half are aware that they could get supplemental income if they're unable to work, or that they could have access to housing, or how to pursue that. So it is a underused probably benefit that exists.
I mean, I think COVID just lay bare all of the problems around farm work in the United States, based on the policies, like the immigration policy. So it all brought up all of the things that have not been functioning for many years.
Wow, thank you for that. That context is so rich and definitely informs what we're seeing in the data. So the next question comes, and it focuses on exposure risk. So what have you found to be, or what do you hypothesize to be, the relative contributions of shared transportation, shared labor housing, or the work sites themselves on exposure to COVID and risk of developing
So I think that's something that we still need to dive into, and this is I opened up data files Tuesday night with glee to start actually getting into this, but we'll be seeing in 3 times the number of people that we've analyzed so far. Ultimately, I think one of the universal exposures here is the transportation. 35% of those who are in our study say that they are involved in shared transportation with non-household members, and we also see a gradient of about 11% antibody positive among those who have no shared transportation, to almost 40% antibody positive to people who are in a bus, essentially, with 15 or more non-household members. So just because that is a fairly prevalent exposure, and also associated with a pretty big risk gradient, I think that strikes me as one that's going to be relatively important. It's also true of people that work in all kinds of different environments. What crop they're working, or whether they're indoors or outdoors. I mean, that is a more universal exposure, and I think that's one that's important. In terms of the specific conditions of work, it does vary a lot by the crop they're working, which is also why we asked a lot of detailed questions about what they are engaged in terms of farming. And so we also ask a lot of questions about what precautions that take in fields. There might be differences in small farms, large farms, or farms that grow different kinds of produce in terms of what precautions people take in the context of the different work that they're doing in that environment. So I think that remains to be seen. Then last, over half are living in statistically crowded households, and we do see association of crowding with the risk of infection, cumulatively, in terms of the antibody data. So that, again, being a prevalent exposure, not just one kind of work, not just one crop, just the fact that almost all of these people are living in crowded households, and that is a risk factor that we're identifying even in this population of universally crowded people. I think that strikes me as one that's going to end up being quite significant here.
I mean, I think what Joe is saying is that we need the larger numbers, and we hope to be getting more numbers before the end of November. And that would allow us to maybe separate out, like, how much of it is the transportation, how much of it is the crop, and how much of it is the housing. Because to some extent, the transportation is related to what they're doing, in that they're more likely to be transported to the fields if they're field workers than if they're in the packing shed, for example. So they're not independent variables completely. And so that's why we need to look at them all together.
right, we have one clarification question. The study team determined the COVID-19 test results and contacted participants about their results. Is that correct interpretation?
So no, what we do in order to get a valid questionnaire is we take the brief window of time between when they get a test and before they're notified of the result to ask them all of these questions. And then, when we know, that we're going to be testing, for instance, a particular crew, or we have people who are pre-registered to participate in the study because we reach out to, patients coming to the clinic beforehand or something like that, then we actually try to get the questionnaire data the day or 2 days before they're tested. So we have a kind of a narrow window of time when the test is, indicative of their current infection status. The questionnaire will be indicative of their recent exposures, but they're not yet aware of whether they're infected or not. And we use that window of opportunity to get this data.
Gotcha. And also the language that the workers are notified is in the language that they note, right? Or in their preferred language.
I think CSVS has some people who do speak indigenous languages, maybe, but not many. And so, most of this will be in Spanish.
And also we interviewed in Spanish. So if someone did not speak an indigenous language, but they spoke Spanish well enough, then we interviewed them. If they spoke only an indigenous language, they could not be included in the study.
Gotcha. All right, and our last question is, what is the timeline for this study to kind of gather to communicate our interest in finding out more about the results? What's the timeline for the study and how can we stay updated about the results?
So we're hoping that the timeline is very, very fast from this point forward. It was a difficult study to get set up, and it's been, I think, a difficult study to run, even in the context of how COVID has made every study difficult to run. This has not been an easy one for a lot of reasons. But we are now, we're at the tail end of collecting data, through November, and I think in the next few weeks actually we'll be at a point where there could be a release of results in a preprint to make that available.
We hope to reach an N of 1,000. That's our goal.
Yeah.
And we'll take bets.
we take bets every recruitment event, every food drive where we're texting each other about bets on how many people we're going to get. So but we in terms of how this is going on, it's what the release of final results is incremental and based on when we're getting specimens processed and able to have matches to people's records in the clinic. But throughout this, there's been regular updating of the Monterey County Coalition that Dr. Eskenazi runs, and regular feedback with them about what we're doing, what opportunities are to expand what we're doing and what we're finding, sort of in that specific stakeholder group that has a weekly meeting where we can share what's going on with the community and people in a position to change things as well. So that's been a really a great asset.
Well, thank you so much, both of you, for spearheading such an important research study. We're looking forward to hearing more about the study in the future. And so we want to, on behalf of the Center for Communicable Disease Dynamics in the Harvard T.H. Chan School of Public Health, we'd like to thank you, Dr. Leonard, and also Dr. Eskenazi for joining us today. I'd also like to thank the audience for tuning into the COVID-19 and Health and Equity Seminar Series. This is the last talk of our series, but please stay tuned to the CCDD website to learn more about upcoming talks and upcoming events. Thank you again for joining, and we look forward to more really good research.
Thank you.
Thank you.